Let's see. Let's hope the technology works properly. Hopefully, you all are seeing um, seeing the slides. Are you seeing the slide? Yeah. Okay. All right. Cool. So I thought I'd cover a few topics briefly and just open it up to your questions, and feel free to interrupt, ask questions as we go. In terms of the global epidemiology, this is the 10 countries most affected by COVID, and United States is in the green. We are still number one. There has been some improvement in the numbers lately, as you can see, and that is also reflected locally here in King County. This is the King County dashboard that is used to sort of track the virus. And having really peaked rather badly a few weeks ago, overall conditions are improving. We're still higher, much higher, frankly, than the target of less than 25 per 100,000 people number of cases for the last 14 days. But on the other metrics of whether the outbreak seems to be growing or shrinking, we're doing better with an R value of estimated 0.5. Risk of hospitalization and of death seem to be flat or decreasing. So, so there's room for optimism here, but as I think I'll show, there's also some real legitimate concerns looming ahead as well. Despite that improvement, I mean, we still are at a very high risk level, given just how high the number of cases are. The test positivity rate, honestly, you want that to be less than 5%. Anything higher than that suggests that we're not testing quite enough, and therefore are missing quite a few cases. So that's the local epidemiology. Now, some of the major news lately has been about the vaccines. Thought I'd talk about that a little bit. And before we go into that, just a little bit of background. This is the coronavirus on the top, and it's got these spikes that protrude from the surface. And in this picture, one of those spikes is attaching to the receptor on the surface of a cell. This is the ACE2 receptor, which is how it binds to the cell itself. Now, the key strategy of this vaccination program, virtually all vaccines, is to induce immunity against that virus. And in this case, all the available vaccines are trying to spur the body to develop antibodies that would block that same spike so that it cannot bind to the host cell. And there are different technologies for doing that. And what's kind of interesting about what's going on now is that the two broadly available vaccines we have are using an entirely new technology for vaccines, which is that they insert genetic material directly into the body, and then that genetic material spurs human cells to make the antigens that then spur the body to develop antibodies. So this is the way it works. The vaccine contains innumerable little particles surrounded by lipids that contain messenger RNA that's injected into the body. Those lipid particles fuse with the host cell. That messenger RNA is then delivered into the host cell, and it then gets translated by the host cell's machinery into spike proteins. And these are the proteins that then are assembled into the protruding spikes of the virus. So the host cell is building these spike proteins and expressing the spikes themselves as well as the spike proteins on the surface of the cell. And the immune system then comes along and sees this and says, wait a minute, these spikes, these spike proteins, they don't belong here in the body. These are not a normal part of the human body. So an antibody response is generated, and not just antibodies actually, but also what are called T cells. And in the process, those cells are destroyed, but more importantly, the immune system now has a memory of having encountered these antigens, these spike proteins. And so in the future, if it ever encounters a real thing on the surface of a coronavirus, then it is primed and ready to directly attack it and keep that infection under control. So very interesting technology, and actually a very effective one. These are data from the Pfizer BioNTech vaccine. This was the first one that was FDA approved, and I've highlighted in red the efficacy rates of that vaccine in clinical trials. And it's 95% effective in preventing COVID illness, which is really quite astounding. I mean, the FDA threshold for approving a vaccine against COVID was 50%. We were hoping for anything that was more than 50% effective. And so to get something that is 95% is really like just hitting a grand slam home run right off the bat. Furthermore, what's also extremely encouraging about these data are that it seems to be equally effective in those who are 55 years of age and older. So even in older folks who we know generally do not have as robust an immune response to challenges, seem to have a very effective response to this vaccine and are highly protected by this vaccine. Now, side effects can occur, but fortunately, they are not severe. The most common side effects with the vaccine are fatigue, headache, muscle pain. The top bar shows the reactions after the first dose. The lower bar is the reactions after the second dose. They actually tend to be a little bit stronger after the second dose. And while these reactions are common, they're, again, really generally not severe. Very uncommon to have a really bad reaction. The exception would be that there have been some cases of anaphylaxis that have almost all occurred in people who had a history of anaphylaxis to something or other. So right now, if you have a history of anaphylactic reactions to vaccines or something else, you may not, you are actually sort of disqualified, at least for the time being, from getting this vaccine. But other than that, not a very big deal in terms of reactivity. Among older individuals, we see a very similar pattern, just the side effects are not quite as pronounced, which actually kind of fits with what we know about older individuals having a less strong immune system in general. Now, this Pfizer vaccine requires 2 doses, about 3 weeks apart. The laboratory data they had suggested that immunity would start to kick in at about day 12 after the first dose. Full immunity not until 4 weeks out. Interestingly, however, the data from the actual clinical trial suggested otherwise in a good way. In this graph, every individual COVID infection among trial participants is symbolized by either a red square in those who receive the placebo or a blue circle in those who receive the active vaccine. And if you look closely, you see these two curves really diverge starting at about 12 days after the first dose. And remain relatively flat after that in the vaccine recipients, suggesting that really a pretty high degree of immunity kicks in just in less than 2 weeks after the first dose of this vaccine, and even before getting the second dose. And this has led some some public health experts and others to suggest that, given the shortage of vaccines out there, maybe we should really be going all out on getting that first dose in people and not worrying all that much about getting the second dose exactly 3 weeks out. Maybe we can delay that a little bit. It's a controversial idea, but one you may have heard about, and basically this is why. Because it looks like you get pretty darn good protection after just one dose. Now, of course, the Pfizer vaccine is not the only player out there. In fact, the Moderna vaccine is now more commonly used. That was the second one out of the gate that got FDA approved. And this one has a virtually identical efficacy rate. About 94% is what they saw in their clinical trial. Now, this Moderna vaccine requires refrigeration and freezing. And even though that is a bit cumbersome, it's actually much less of an issue than it is with the Pfizer vaccine. The Pfizer vaccine has to be kept at 70 degrees Celsius below zero, just an extremely cold temperature, which raises all kinds of issues with cold chain, transport, storage, et cetera. The Moderna vaccine is a bit more forgiving in that regard, which is probably why it's starting to be more widely used. And so if you look at the effectiveness of both of these vaccines, with the Pfizer one in red and Moderna in green, you see the efficacy hovers right around 94, 95% for both of them. They're identical technology. So this mathematician sort of pooled the efficacy, and it suggests that, we can be very confident that the effectiveness in the real world is going to be really somewhere between 90 and 97%. So very encouraging news with those two vaccines. Now, there are other technologies being used. This is sort of an older vaccine technology in which you use another virus to basically introduce the genetic material of the virus we're trying to build immunity against into the body. So Johnson & Johnson just made a press releases yesterday about their vaccine. And so you may be hearing a little bit about this one in the news. It's not quite as effective as the Moderna or the Pfizer ones. In the United States, it was about 72% effective in terms of preventing moderate and severe disease, 85% effective against severe disease. So actually really quite good. And again, if not for the Pfizer and Moderna vaccines that had such astoundingly high efficacy, we would really be celebrating the arrival of a vaccine this good. It's also a lot more convenient than the other two vaccines out there because it requires just a single shot, and it just requires standard refrigeration. It does not need even to be frozen at any point. So a lot easier to transport. Now, the efficacy though, this was tested globally, and globally the effectiveness was more like 66%. And so it sort of varied by region. And in South Africa, it was only 57% effective in preventing moderate and severe disease. But locally, again, United States, at least so far, 72%, very well tolerated. They're expected to apply for emergency use authorization next week. Probably receive it sometime in February. We might start seeing that vaccine come out as well. And then there's the AstraZeneca Oxford vaccine. This is a vaccine that uses a very similar technology. It uses a modified adenovirus to deliver DNA. And this vaccine, interestingly, has sort of a range of effectiveness depending on the dosage. Because the, excuse me one second. Okay. All right. So they basically made a mistake during this the trials because the participants in the United Kingdom, um, due to a mathematical error, ended up receiving only half of the strength of the first dose of the series, and that was originally planned for. But interestingly, those individuals who only got the half dose appeared to have a much better response. Their response rate to that half dose was 90%, whereas those who got the sort of standard and planned dose, higher dose for the first shot, only had a 62% protection. So people have been really scratching their heads over this. As to what does it really mean? Is this just some sort of statistical fluke, or is it real? Bottom line is we don't know for sure yet. There have been some other issues with the data being submitted on a timely fashion by AstraZeneca. The bottom line is we're not very close to having this vaccine available here in the United States, though it is being used elsewhere in the world. So if you're trying to keep track of this on a scorecard, this is kind of an attempt to summarize the characteristics of the main vaccines out there. The Oxford, AstraZeneca one, again, range of effectiveness, not going to be used here anytime soon. The Moderna and the Pfizer vaccines in the middle there, both require 2 shots, extremely effective, 95%. They do have some cold chain requirements, especially the Pfizer one, which needs to be kept very, very cold. And then lastly, the Johnson & Johnson, which we are going to start seeing pretty soon. Much easier to administer and transport, not quite as effective as the Moderna and Pfizer ones. Now, so the vaccination news is definitely very good news. But that news has to be tempered by the appearance of these new strains of the coronavirus that you've probably been hearing about in the news. So the story really starts in South Africa, where an infectious disease nurse in Durban, South Africa, noticed an unusually rapid growth in cases last October. So she arranged for genetic testing of samples from the region, and it was discovered that it was a mutated strain of the coronavirus that now has, well, various names, 20C/501Y.V2 or B.1.351. She contacted colleagues in Great Britain who had noticed another cluster of cases in Kent, a little bit farther down the line in mid-December. Sure enough, genetic analysis of that strain disclosed a mutated version of the virus there as well, not the same one as was seen in South Africa, a different one that is commonly known as B.1.1.7 lineage. Now, this is an example of what looks like convergent evolution because, again, these evolved independently, right? But with the same outcome, in that these strains appear to be more successful in terms of latching onto target receptors in the airway epithelium and thereby generate higher viral loads in the respiratory tract. They even have a few mutations in common. Now, each of these strains is estimated to be roughly 50% more contagious than the sort of strains we've been familiar with over the past several months. And 50% more contagious, that's actually a very significant increase in infectivity, as I'll show. So again, the mechanism here, we're looking at the coronavirus with these spike proteins protruding out. The little blue area at the tip, the light blue area is a little hook where it specifically binds to the receptor. And it's worth noting that this is not a totally new phenomenon. This virus has been mutating all along. And in fact, back in February, there was a replacement of a prior strain with a new strain that because the new strain was more infectious. And that was a transition from D614G is the nomenclature. It means that codon number 614 in the sequence that codes for this spike protein, where before you had a amino acid residue abbreviated D, now you have G. Ultimately, it leads to a spike protein that's better at attaching to the cell membrane. Now, the difference with the UK strain is that rather than just a single mutation, there are 17 mutations in the spike protein that have led to this increase in infectivity. And that really surprised the researchers to see that many mutations occur in such a relatively rapid fashion. It was thought that this coronavirus would mutate relatively slowly, so it was a little bit shocking to see this many mutations accumulate this quickly. And they've even been able to figure out, how some of these mutations work. This is another picture of the coronavirus attaching to the receptor on the cell surface. I've sort of inverted it because of what I'm going to show on the next slide. But basically, you have the coronavirus spike there trying to bind to the ACE2 receptor on the cell surface. And what they have found is that one of the key mutations, which is called N501Y, results in a change in the amino acid at a critical part of the virus, which is shown in red, that allows for more binding sites to the receptor. So just by changing the amino acid N, which stands for asparagine on the left, to Y, which is tyrosine on the right, instead of having just two places of binding to the host cell receptor, now you've got about 10. It's a pretty interesting phenomenon, for those of you who teach biology and look at biochemistry. So that's just one of the mutations, but it seems to be one that's shared, that's common to both the UK and the South African strain. So it seems to be pretty important as well. So what are the implications of all this for epidemiology? Well, in the United Kingdom, the new strains are represented here in orange, was kind of lurking at low levels throughout October and November, but really kind of exploded there in the month of December and rapidly started to replace the older strain as the most common circulating variant of COVID. And what you saw with that is a dramatic spike in the number of infections in the United Kingdom. And an even more dramatic spike in Ireland, which Ireland really had things under control until this new version hit. And then cases suddenly spiked very severely upward. And it prompted Tom Frieden, he used to direct the Centers for Disease Control, to say, "I've never seen an epicurve like this. The B117 variant is spreading like wildfire in the UK and Ireland. If it spreads here, it will make an already bad situation even worse." Now, of course, the variant is here. It's as well as in many, many parts of the world. And this is probably a vast underestimate because there aren't many countries in the world that are actually doing the detailed genomic sequencing of strains of the virus to establish, exactly what variant they have. Here in the United States, it's present in 29 of the states. It's been detected. And even here in the United States, we only sequence maybe 1% of the strains that are detected. So we're not sampling very hard either. And yet we picked it up in 29 states, including here. There are 2 cases that were detected in Snohomish County just last week. And what's kind of jarring actually about this headline is you see that headline and you see right above it that the governor has actually loosened restrictions. And it's I guess it raises concern that now may not be the right time to be loosening restrictions when we're starting to see a far more contagious version of the COVID virus entering our communities. Now, I also alluded to the South African virus. That one is here in the United States as well. It was detected in South Carolina just last week. Again, because we only sequence a very small proportion, it's quite possible it's elsewhere in the United States as well. So what are the implications? Well, another former CDC director said the danger of the new COVID variant isn't that it's more severe, but that it's more contagious. If more people are infected, this will increase the burden on already overwhelmed hospitals and lead to more deaths. And this is kind of a nice visual to try and sort of show how that can happen. So let's say we've got this situation, and on this this graph or this pictorial, every person represents 10 infected people. And let's say we have a community that has a consistent 1,000 new cases per month, and it's neither growing nor shrinking. So in technical terms, the virus's reproduction rate, or R, is 1. Every month, you've got 1,000 cases, new cases, no more nor less. It's a very stable situation. Now, if we introduce a new strain of the virus that is 50% more infectious, which is what the UK strain is estimated to be, which is about what the South Africa strain is estimated to be. In 1 month, you've gone from just 1,000 cases per month to 10,000 new cases. And it's going to continue to sort of grow exponentially. And so that's just a 50% more infectious strain. We see a similar phenomenon occur if we look at mortality. So in this case, we're assuming we've got a community with 10,000 infections. We're also assuming in this model there's 1.1 new cases, is growing slightly, and that around just under less than 1% of new cases result in death, which is, I think, a fairly accurate estimate of where we are in the United States with the case fatality rate here. So in that scenario, in 1 month's time, you get about 129 deaths from the virus. But again, if you introduce a strain that's 50% more infectious, and again, we're not altering the mortality rate, we're not altering the lethality of the virus itself. We're taking the same strain, just making it more infectious. After a month, you've got nearly 1,000 deaths. So, an over 600% increase. So the math here can be pretty frightening, owing to the exponential nature of infectious diseases like the coronavirus. And of course, it doesn't end after 1 month. It keeps going up and up and up on an exponential rate. And it's worth noting that if you had the choice of having a strain of the virus enter your community that is either 50% more lethal or 50% more contagious, you actually want the one that is 50% more lethal, because in the end, that's going to result in far fewer excess deaths than is the one that is more transmissible. Now, again, I've been talking about it as if it's the same lethality, but questions have been raised about the UK variant, specifically. Is it more lethal? Is it more deadly? And in fact, it looks like, unfortunately, it is. There have been several small recent studies in the United Kingdom, but all of them seem to coalesce and point in the same direction, that this new strain they're having is more deadly, with anywhere between 30% to 90% higher death rate associated with it. So these are preliminary, these are small studies. We can hope that they'll turn out to not be true, but even Tony Fauci of the NIH agrees that it's looking like this is also a more deadly strain, in addition to being more infectious. Another concern is, will our vaccines work against these new strains? We sort of have conflicting data regarding the strain from the United Kingdom. I mean, these are just two headlines that I copied from the news recently that that refer to differing results. And if you go to the original literature, you see a study showing that the blood from people who have recovered from COVID works just as well against the new variant as it did against the old one. But then there's another study suggesting that it doesn't work quite as well. Now, both of these studies are from what's called a preprint server, meaning the studies have not been peer reviewed yet. They should be interpreted with caution. So I would say we don't really know for sure just how well the vaccines might work against the UK variant. There's sort of conflicting evidence to date. The studies I just referenced were with respect to the efficacy of the Pfizer vaccine. Moderna has done its own studies as to how well its vaccine performs against these variant viruses. They found that their vaccine worked just as well against the UK strain, the B117, but did not work, appeared to not work as well against the South African variant as it did against the earlier strains of the coronavirus. And this is just one of the studies that sort of corroborates that finding from Moderna, in which individuals who had recovered from COVID, the old COVID, their plasma was tested against the new strain and discovered that bottom line is the efficacy of the antibodies in these recovered patients against the new strain from South Africa was only about 50% as compared to what it had been against the prior strain. So I think there's emerging evidence that the vaccines we have now, at least Moderna, probably Pfizer, likely not as effective against the South African strain. Not sure at this point about the UK strain. Now, Moderna is already starting to look at tweaking its vaccine to try and make it more effective against these new variants, and it may not take like a year or so. Okay, so it may only take on the order of, let's say, several weeks to come out with a new version that works better against the new variants. But then you face once again the massive distribution and logistical challenge of actually getting people vaccinated with the new vaccine if it comes to that. And so they're working on versions of the vaccine that will hopefully be more active against these strains from the United Kingdom, from South Africa, and Brazil. Oh, Brazil. Brazil has a new strain as well. To their credit, they have given it just one name and a simple one, P.1. But there is quite a bit of concern about that strain as well. They saw a dramatic surge in cases in Manaus in Brazil, where it was estimated that already 75% of the residents had already been infected. And so you would not expect much of an outbreak to even be possible in an area like that, given the level of herd immunity that had already been established. And yet they saw this dramatic flare of new cases there. So people are trying to figure out why it spread so explosively. They know it carries a lot of mutations, and they're worried that those mutations might, in a similar fashion as the UK and South Africa strains, make it more infectious. And yes, it's here in the United States as well. It was detected in Minnesota just last week. So, so the implications of these new strains is rather discouraging. And I think the summary is pretty good. We have entered a new phase of this pandemic. On the one hand, vaccinations have started. On the other hand, this new variant, and actually we should update this, these new variants are spreading faster, potentially causing a lot more sickness and death in a short time. And furthermore, it means that more people will need to be immunized in order to reach herd immunity. It's not what anyone wants to hear, but the coming months may well be the hardest of this pandemic. If you've been thinking of vaccines as the light at the end of the tunnel, yes, that light is there, as bright as ever, but the tunnel just got a bit darker and a little bit longer. So what do we do in the meantime? I think in the meantime, it's important to pay attention and double down on the interventions that we know do work. And this is a kind of a public health perspective, illustration of how these various interventions work. And it's called the Swiss cheese model, because it's sort of like multiple slices of Swiss cheese, with each slice representing a single sort of strategy or intervention to try to help control the pandemic. And every single one of these slices, as it were, has holes. No one intervention is going to solve the problem for us. But if you stack enough of them, and if you make the holes in each one small enough, it makes it very difficult for the virus to sort of figuratively pass through all of them and lead to more infection. And so there are personal responsibilities here, including physical distancing, masking, limiting your time in crowds, cough etiquette. Then there are shared responsibilities, systemic interventions that can occur, ending, of course, with vaccination programs. And we've spent a lot of time talking about vaccines, and so they are going to play a significant role, I think, in ending this, but it's going to be very slow for them to have the impact we need. And furthermore, there's this complication of that they might not work as well as we had hoped against some of these new strains coming out. The rollout of the vaccines has been slower than we had hoped. And honestly, we're going to have to keep on going at it for many, many months before we get this under control. And then one of the other parts I like about this model is the disinformation mouse, which is steadily chewing new holes in many of these slices of defense for us. So I hope that this is provide a little bit of service in terms of taming that disinformation mouse. And I think I'll just stop there and open it up to any questions in the discussion. I'd certainly like to answer what you're most interested in.
Well, thank you, Dr. Behrens. Terry, do you want to just ask your questions? I know you typed a couple in.
Sure. The first question I asked is, you showed the chart where you drew out the side effects after a first dose and the side effects after the second dose. And if you had those side effects in the first, does it mean you'll have more or less side effects in the second dose, more severe or less severe?
Yeah, good question. I mean, this is the graph you're talking about.
Yes.
So I think generally, if you had side effects from the first dose, I think there's, my hunch is that you probably would have side effects from the second dose as well. It sort of means your immune system is configured in a way that responds to that vaccine with a lot of inflammation. It's inflammation that is driving all of these side effects. And of course, that inflammation is kind of a marker that, well, at least your immune system is reacting to it. So I have not seen any data to, confirm this, but I haven't really looked for it either. I guess my hunch is if you had a reaction to the first one, yes, it's a good chance you'll get a reaction to the second one.
Okay.
And the general pattern is side effects tend to be more severe with the second shot than with the first. I mean, I and many of my colleagues have had these vaccines. Just talking to other people, most of us, including myself, had nothing more than a little bit of soreness in the arm.
Mm.
But I've had a few people talk about how they were, pretty sick
Yeah,
for a couple of days.
yeah. I
yeah.
have had the vaccine, and
Yeah.
so I had the headache and the fatigue, but that whole sense of having a foggy brain and being chilled and just almost like you had the flu after that first one for about 24 to 30 hours. And then it was like a new day,
Yeah.
all gone. And so I was curious if I didn't realize they had charted out these side effects, if what they really meant for your second dose. So
Right. You could take, Tylenol and or ibuprofen prior to the second dose. It may sort of
prior. Interesting.
temper the, inflammatory reaction, make it
Yeah.
a bit less severe.
Okay. And then the other question that I had was the new variant. Has there been any research or studies or indication of the effect on young learners? I mean, we've been so fortunate that the original coronavirus did not impact young people as much. Is that still the case with the variants, or do we know yet?
Mm-hmm. We do know that with the UK variant, there's no difference in terms of sort of the age and gender distribution of who it infects. It appears to have the, basically identical pattern, just for every age group, a bit more likely to infect them. The sort of severity of illness, the only data we have are what I showed with respect to mortality rates. And those are generally in older individuals. So I don't think we know if the UK strain or any of the other ones, where was it, result in more severe illness, say, for younger persons.
Okay. Then a third question I would have is, do you think that the quarantine guidance will change based on this rapid rate of being contagious? Like we do 14 days now, if you've been exposed, do you think that that would be longer to make sure that it's not there? What are we going to do that will stop the rapid rate of exposure?
Right. Well, I doubt the recommendations around the length of quarantine and isolation are going to change. Really, if you want to stay ahead of these new strains, we have to be more aggressive about social distancing and masking in the first place. And right now, as you probably heard, I mean, as of just yesterday, we're actually moving in the other direction with King County, Snohomish, I think 7 counties in Washington State actually moving to phase 2.
Yeah.
Right.
Yes.
So, and to be fair, I mean, that's based on to a large extent on the numbers that I showed initially, with most things headed in the right direction. Although Inslee did loosen the criteria for moving on. It used to be you had to be, meeting the targets on all 4 of those metrics. And then he changed it to, well, if you're meeting 3 of 4, that's good enough. I mean, I'm sure he's under a huge amount of pressure to allow businesses to open up, and that's a very real thing. But obviously, the risk is that we might be opening things up at precisely the wrong time when we're starting to actually see these new, more aggressive, more infectious variants come into our communities, which would allow them to spread even faster than they otherwise would. I guess all we can do is wait and see what happens. But I think on a, sort of on a personal level, I would still favor, what I showed with the Swiss cheese model. We all really should be doing everything we can to keep those holes as small as possible in every slice that we can.
Okay. I'm just trying to anticipate as we close out the school year and anticipate the fall, if this is now here and spreads that rapidly, what it means for bringing more students back on campus. And that'll be the issue for us as schools.
Yeah, in the fall, I mean, I've heard estimates, including by Tony Fauci, who, I sort of trust more than anyone else on this issue, that the UK variant could be the dominant strain in the United States by March, right? So that could really, I mean, you saw what it did in the UK and Ireland. And then of course there are these other strains. So it wouldn't surprise me at all if we're dealing with, new strains of this by the summer even. As by the time the fall approaches, I mean, we're kind of in a race between these new strains versus vaccinations. And then of course, I mean, if things go sort of badly in a way, then we're looking at more herd immunity. So there are these three variables in question here: the infectivity the strains will have, our success in vaccinating, and the amount of herd immunity we'll have by then, that I think will really determine the contours of, the pandemic in the fall. And it's just very, very hard, I think, to predict how those are going to play out against one another. But they're the things to keep an eye on.
Yeah, thank you very much. I appreciate it.
Yeah, sure. Let's see, I don't know, is there a chat? I'm trying to see if there's a chat box. Any other questions?
I think you got them all.
Okay. All right. Yeah, and I know that the CDC released a report earlier this week or last week, very recently anyway, really calling on schools to reopen, and I think with good reason. And I mean, we know how hard it is on so many students to not be coming to schools. And I mean, generally, while I haven't looked at the individual studies they cited in detail, I mean, I now trust the CDC with its new director and its new sort of outlook. So I would trust their guidance on that. But I guess you have to hedge your bets a little bit, because the guidance they provided and the recommendations they've generated are based on experience to date with the older versions of the virus, with an earlier phase of the pandemic, so to speak. And will that experience apply if we're suddenly dealing with a strain that is 50% more infectious? That's the question.
So the one example I would use, the old virus, it's a way to call it. We were beginning to look to see and start to have conversations, would the state ease up on social distancing within classrooms? But with a new variant coming on, that social distancing sounds like it's going to be highly important. And so it probably won't be lessened as quickly as we would have hoped, which would allow us to bring more students on campus, because we do want to be open and we do want to provide services.
Yeah, I think that's important. I think also a close look at the masks that people wear, because there is really quite a spectrum of effectiveness of various masks. And now there are, these K95 or SK94 versions of the mask that are actually reasonably comfortable. And I think getting better and paying more attention to the quality of the masks we use is something we should be looking at.
That's
and then
good
dining
advice.
areas. I think based on what I've seen occur at like Harborview, where I work, and just thinking about it, I think in places where people are dining together, that's really a really risky place for transmission. Because you can't possibly be wearing a mask while eating. And when you're eating, you're generating these aerosols as well. And we've certainly had small outbreaks at Harborview that have been linked to break rooms and eating rooms. So much so that, it's recommended now that if possible, just eat alone. Don't even eat in a common space, which has been challenging. I mean, it's winter, for crying out loud. Where are we supposed to go eat? But nevertheless, that is the reality. So, so paying attention to the masking, dining spaces, and ventilation everywhere.
Okay, thank you.
Sure.
I don't have any other questions. I don't know if Matt's still on or not.
I'm here. You are good to go. Thank you, Sandy. So I'm actually, we have a fish fry, so I'm dishing out fish pickups on a drive-through only. It's not a gathering, just to clarify. But Dr. Behrens, again, I did miss a few things here, but and I don't know if you spoke to this, but a lot of chatter on double masking. Did you already speak to that?
Yeah.
About, like, whether that's effective or not, or?
Generally, it is. I mean, but it kind of matters what fabrics you use, and what kind of masks you use. And I was mentioning that there are these. It's now possible to get relatively cheaply, N95 quality masks that are reasonably comfortable. So it's worth looking into that. And the N95 masks, you can cover that N95 mask with a very simple surgical type mask that, sort of prevents that from getting, I don't know, too exposed, and so you can reuse it over again.
Yeah.
A simple cloth mask doesn't necessarily do a lot, but if you have two different fabrics like cotton, and then couple that with a kind of a polyester, something that has a sort of static charge to it, that combination seems to work really well because of the electrostatic charges coupled with the physical barrier. There's some literature around that too. So having said all that, ultimately the most effective mask is the one that you're going to wear. So, you can get the absolute best mask out there, but if it's too uncomfortable to wear and you find yourself not wearing it very often, and of course that applies to kids as well, then, you've sort of lost the point.
Yeah, those N95s are not comfortable.
Right, but I think it's worth looking at the options out there. I mean, there's an N95 that I wear, at work around tuberculosis patients, and I hate wearing it. But then there are, I don't know, I guess I think of it as N95 light. It hasn't been, fully form fitted and tested and all that stuff. So I'm sure it's not quite as good, but nevertheless, it's a lot better than nothing, and probably better than a simple cloth mask.
Okay. Mostly for adults, or should we be looking at those KN95s for children, students as well? Or
for children and students, yeah, absolutely. Yeah. Yeah, and I have not done a lot of research into the options out there for children. I just think that should be a focus as we move on. All right, looks like the fish fry is going well.
Yeah. All right. Well, Dr. I so appreciate this. You've given a lot of information. And I'll share this information as we move along within our own schools. So thank you very much.
Yeah, sure. And I'll send along a copy of these to Matt, and he can distribute it to everybody.
Okay. Thanks, Matt. Thanks for hosting.
Yes, thank you, Dr. Behrens. Thank you, Terry, Ms. Tomich, Ms. Schwartz for joining us. That's not really Miss Nicole, that's the computer that's recording us. But yeah, very, very helpful. I'm gonna watch the full thing to see all the parts I missed. But Dr. Behrens, thank you for the work you're doing and
Thank you.
spreading the knowledge. And we'll try to get rid of that mouse
Yeah.
of disinformation as much as we can.
You
I
do
like
it
that.
every day.
This information.
It's your
Okay.
calling.
Thank
All
you.
right.
Have a good weekend.
All right.
Have a
Blessings.
blessed weekend. Thanks again.
Okay,
Bye-bye.
you too.